Awesome. I think I can do this. Perfect. So yep, I'm currently on the NIDA T32 at Stanford, and like I said, no other conflicts of interest. I'll give a super brief overview about chronic pain and opioid use disorder. Generally, we see in those who do have opioid use disorder, about half or up to 65% of patients also have comorbid chronic pain. And majority of these patients, upwards of 85%, report onset of chronic pain before OUD. Medications for OUD are buprenorphine, naltrexone, methadone are the gold standard treatment for OUD, and they're really effective at reducing relapse and craving. And generally what we find in the literature and meta-analysis has borne this out is that the presence of chronic pain actually does not predict relapse or return to opioid use. However, when we start to look proximally at pain, so looking at past week pain, pain on the day, or a really highly volatile pain, we start to see differences in rates of relapse. And folks who do have chronic pain tend to have worse outcomes of MOUD treatment as compared to those who do not have chronic pain. And the study I'll briefly go over today was my dissertation that I did at the University of New Mexico during my grad work. And I really wanted to understand this heterogeneity in the MOUD treatment response and really understand what is the impact of MOUD on pain, as well as who benefits from this treatment and who doesn't. And lastly, I also wanted to assess functional outcomes as well. Typically, especially in SUD treatment, we can be really myopically focused on relapse. And so I really wanted to also look at other functioning outcomes and really using a person-centered lens to this data. So the data that I'll present and the models that I use are person-centered, meaning that I'm not opposing a structure on the data. I'm kind of letting the data speak for itself. And so to do this, I examined profiles and transition in profiles between pain intensity and pain interference over 12 weeks of buprenorphine maintenance treatment. And I looked at differences in outcomes at 12 weeks while folks were still maintained on buprenorphine, and then at 24 weeks once they had been tapered off of buprenorphine. And I looked at the role of patient characteristics, both in relation to their profile membership, and I'll talk about the models and what that means, but also transitions between profiles. And so this was a secondary data analysis of the Weiss et al. Trial, the POTS prescription opioid and addiction treatment study. It was a big, large RCT that recruited from 10 community SUD clinics across the United States. These were primarily adults who had a current diagnosis of prescription opioid use disorder, and all patients in the study did receive buprenorphine. They were randomized into two different arms. So there was standard medical management and then enhanced medical management. In the bigger study, they didn't find any differences between these arms. So in the results that I'll describe today, I collapsed against these treatment arms. But standard medical management was just meeting with a nurse for about 15 minutes to talk about buprenorphine dosing, abstinence goals. The enhanced was a 45-minute long counseling in addition to those nurse visits. And we examined in this subset of folks, those who did have chronic pain. And this was a two-phase study design. The study design would not fly these days, but the first phase was they were randomized to buprenorphine for only 4 weeks and then subsequently tapered off. And then folks who were, quote, failures or returned to opioid use then were randomized into phase 2, where they were maintained on buprenorphine for 12 weeks. Only about 7% of the study actually made it was a success in the phase 1 baseline. And so the data that I'll be presenting is really focused on this phase 2. So looking at the phase 2 baseline assessment, the week 12, and then the week 24 assessments as well. And these are the models. So this is just one of the models. This is the pain intensity model, and I used latent transition modeling to derive profiles at that phase 2 baseline, and then at profiles at week 12. The indicators for this were the BPI. So this pain intensity model is using the pain intensity indicators for the BPI. And then we looked at a number of patient characteristics to see, are these related to their profile membership at either time point and in relation to their transitions between profiles. And then, like I said, we looked at outcomes at week 12 and at week 24. The pain interference model looks exactly the same, except on the bottom indicators are the BPI for the pain interference subscale. And so jumping into sample demographics really briefly here, mean age was about 35 years old. We had a primarily white sample. And most people, or about half the sample, reported a pain duration of longer than 4 years. And we had a relatively treatment naive sample here. Most of them had never received treatment for opioids before, and only 6% had received buprenorphine in the past. And these are the descriptive variables. It's a lot to take in, so I'll just briefly summarize them. At baseline, we see folks falling into the mild to moderate severity range for both pain intensity and pain interference. Also the moderate range for depression severity, that is the BDI. And then 69% reported opioid use at the phase 2 baseline, and that was assessed using a urine drug screen. And then we see generally poor mental health quality of life. And we did have significant attrition in the study, as you can see. We did do some attrition analyses, and there were no significant differences on those who had complete versus missing data. We actually saw that folks who had higher depression were actually retained throughout the study, which we thought was interesting, but no differences in opioid or pain severity here. And the models that I'll show as well account for this missing data and attrition. Okay. And so at the phase 2 baseline, you're seeing the pain interference model. We saw that a 2-profile solution fit the data best at the phase 2. This was also seen at week 12 for the pain interference. And you can generally see we have a high and low profile is what that works out to. And same for the pain intensity model. Again, this is phase 2, what you're seeing. We see the same set of profiles at week 12. Again, generally a high pain intensity and a low pain intensity profile. And so looking at transitions here, I'll walk you through the numbers, but essentially what you're seeing are probabilities. So this is essentially seeing we have this high and low profile. What are the probability that they change profiles over time? So this is, again, looking at changes over 12 weeks of buprenorphine maintenance treatment. Those classified in the low interference profile at baseline had a 84% chance of remaining in the low interference profile, and about a 16% chance of transitioning up to the high pain intensity profile. And then you see for those classified initially in that high pain interference profile, 66% chance of transitioning down to the low interference profile, and a 34% of remaining in that high interference profile. And for pain intensity, we see generally the same breakdown. So again, a high number of folks who are in the low intensity tend to stay in the low intensity profile. We have a small chance that they do 13% transition up to the high pain intensity profile. And similarly, a 58% chance that folks transition down to the low intensity profile, and then about a 41% chance that they actually stay in their high intensity profile. And when we look at the role of patient characteristics here, generally we see that those who have a higher depression are more likely to be in the high pain interference profiles at both time points, which is probably not surprising to all of us who treat these patients. And then we see also for the pain intensity model that women were more likely to be in the high pain intensity profile as well, but that did not persist to week 12. Interestingly enough, these other predictors were not associated with profile membership at either time point. And then when we look at transitions between profiles, I was not able to look at opioid use or pain duration, unfortunately, in these transition models due to convergence errors. It's likely due to this small sample size, but the ones I were able to look at were age, sex, and depression severity. We did not have any significant predictors of transitions, and this was a bit of a surprise. We did have, though, we corrected in our comparisons for multiple comparisons. Depression severity and age were significant at the p less than 0.05 level, but when we corrected for our multiple comparisons, that went away. But generally at the p less than 0.05 level, we did see that higher depression and higher age were associated with changes in either direction, high to low or low to high. Likely a small signal there, but like I said, we need to have more data and get a better look with a bigger sample to really tease that apart. And then lastly, when we look at outcomes, we see that those in the high pain interference profile had worse mental health quality of life, worse depression at the end of their buprenorphine maintenance treatment. And they also reported higher average pain intensity and higher average pain interference at week 24 once they'd been tapered off, suggesting that they continue to have these high levels of pain intensity or pain interference. And then we see worse mental health quality of life for those in the pain intensity model, and similarly still endorsing high pain interference and high pain intensity at the end of treatment once they've been tapered off. And so, threw a lot of numbers at you. What does this all mean? Generally, what this shows, at least in this particular sample, is that the majority of people remained in or transitioned to the low profiles, pain intensity and pain interference, over the course of 12 weeks of buprenorphine maintenance treatment, really suggesting that this buprenorphine model, at least in SUD clinics, management may be sufficient for patients who have OUD and chronic pain. This non-responder subgroup, which is about 15 to 20% of our sample, did have worsening pain intensity or pain interference over the course of treatment. And we saw that non-responders were more likely to have depression upon entering treatment, and then of course, worse mental health quality of life at the end of treatment. And so what this obviously suggests is that we need to really have continual pain, assessment of pain and depression over the course of buprenorphine maintenance treatment. And really more of this behavioral research and better understanding, can we treat this depression beforehand before we maybe put them into buprenorphine maintenance treatment, or can we treat it concurrently? Jury's still out and we need more data on that, but this is really an important target, especially for these patients. And then it's important to note that despite this higher pain intensity for women at baseline, they did not continue to have high pain intensity at week 12, suggesting that they did have an equivalent MOED treatment responsiveness to men. So that is definitely very helpful. And really, interestingly enough, we also did not see any differences in opioid use between these high or low profiles, again, suggesting that buprenorphine may mitigate some of that impact of pain intensity on relapse, likely through this third variable of craving. And you can read more. There's a lot of caveats to this study that I couldn't get into in this short talk, but please, it was just published in Journal of Consulting and Clinical Psychology, and I'm happy to take questions at the end. So thank you.